always show this image because I think it really shows us how much we've have advanced. Okay, back in, let's say, the 1950s and 1960s, we had physicians who promoted cigarettes. In fact, they would tell you which one they feel are the best ones for for doctors. Okay, and certainly, we now know the unfortunate potential side effects of cigarettes. The whole world has changed drastically from what was a lot of advertising and support for cigarettes to unfortunate the knowledge of that we've learned that lung cancer and many other cancers have this strong association with smoking. And I'll tell you, as a medical oncologist who treats a lot of lung cancer, a common answer I get when I ask patients, do you smoke? Are you a former smoker? When, and then when did you quit? The answer is oftentimes, well, when I found out I have stage 4 lung cancer, right? And nowadays, there's obviously a large push to stop, individuals from smoking cessation. We have this, significant increase in screening tests for lung cancer. Basically, those that have a extensive smoking history. We are now screening these patients for lung cancer, primarily to find these cancers earlier on. We'll talk about that in the coming slides. Some of the risks that, for not doing screening tests, finding these tumors, unfortunately, at later stages. And so certainly, while this is an older advertisement, things have changed drastically. So lung cancer remains to be the leading cause of cancer death. Okay. In fact, if you add up multiple cancers combined, including prostate cancer, colon cancer, pancreatic cancer, they still don't add up to the amount of deaths that we see from lung cancer. Okay. So in males and females, this is data from 2021. But nothing has changed in this world. And this is worldwide. Okay. So the leading cause of cancer death remains to be lung cancer, and it's by far the leading cause. We've actually have seen improvement, and we'll talk about that throughout the lecture today. In terms of reducing lung cancer death, but regardless, it does remain to be the number one killer of cancer-related deaths. This is a slide. I'll focus on the right side first, depicting what type of cancers there are. So lung cancer is a generic term. There are different types of lung cancers, which I'm sure you probably have heard about before. As it stands today, about 85 to 90% of lung cancers are considered non-small cell lung cancer. That's what NSCLC stands for. The other 10 to 15% are small cell lung cancers. The behavior of the two are rather different. We see less small cell lung cancer than we did previously. That a lot of that has to do with the fact that we have reduced, smoking in the population. Of course, we still have a long way to go in that aspect. But as we've reduced the amount of smoking or cut back on smoking in individuals who previously smoked, we see less small cell, which is a more aggressive form of lung cancer. Non-small cell has, obviously, as small cell has decreased, the percentage of non-small cell has increased. There are different types of non-small cell. So if we kind of move on to the next graph here, 70% of non-small cell lung cancers consist of what's called non-squamous carcinomas. The most common of which is called adenocarcinoma. The other 30% are squamous cell carcinomas. Okay, so even within the non-squamous cell carcinomas, you have rare types, including things like large cell carcinoma, and some other even rare types. The most common non-squamous is adenocarcinoma. The other 30% of that non-small cell is a squamous cell carcinoma. The staging is different. The treatment is different. The approach is different. I won't go into all those details because that's not really the purpose of the discussion, but just understand that there are different types of lung cancers. As it relates to staging of the lung cancers, the purpose of the graph on the left is really to show you that about 90% of patients will present stage 3 or stage 4. The majority of these patients, so if you are stage 4, by definition, that is metastatic disease, you are generally a non-surgical patient. And the treatments generally consist of chemotherapy, immunotherapy, targeted medications. We'll talk about some of these things in the coming slides, but majority of the time, those patients will not be able to be operated on. Operation or surgical removal of lung cancer remains to be the best chance of cure, in this disease. And, the majority of stage 1 and stage 2 are operable. Stage 3, it can vary, but just understand that in general, the majority of patients, unfortunately, do present where their disease is already beyond the ability to be resectable. And that we know now that there are, like I told you, there are screening tests to try and find these earlier so that we can intervene earlier, giving our patients the best chance of cure. And certainly following with your doctors and, understanding, symptoms of lung cancer and working them up is certainly very important. There's certainly been a large change in the way that we manage cancer patients. It used to be that there was this kind of one size fits all, one treatment fits all, where we would know that, for example, patients, and the example here is colon cancer, but lung cancer is the same thing. We would give a kind of like a shotgun approach, give these a high dose chemotherapies, see if there was an effect, if there was no effect, if they had bad side effects, right? And we would then decide, well, can the patient continue on that treatment? Can they go on to something else? That was kind of the one treatment fits all. That has changed drastically, okay? Certainly over the past, I would say 10 years, 15 years, but really significantly more over the past 5 to 7 years. I finished my training in 2018, so it's been 5 years. And my training was 3 years, so go back 3 more years to 2015. We were doing this a little bit in 2015, so that was only 8 years ago. Nowadays, everyone is getting these what are called personalized diagnostic studies. So tests that curtail our treatments based upon a patient's cancer, not the general cancer, but the specifics within a patient's own cancer. And so there are a lot of tests that we do nowadays, and we'll talk about some of these tests that include blood-based tests, tissue-based tests. So basically, you take a sample from someone's cancer, like someone has a lung mass, they get a biopsy of that. We can actually send that tissue out and get a lot of useful information. And that way allow us to give some of that, some of those medications that are better suited for that patient than just the general kind of rapid approach. This is just a cartoon, what we call cartoon. This is our cartoon, but basically a schematic of kind of how we approach our patients in terms of diagnosis. So, let's say we find a patient who has advanced non-small cell lung cancer. These are some of the tests that we do. So the first approach is that we do this kind of sequential approach. And so, the tissue gets sent out. We send it for what's something called next generation sequencing or genotyping. They go through the process of getting that information. And thereafter, depending on what we see on the tissue, we can then send a blood-based test. Another type of approach is that we do the opposite, which is that we do a blood-based approach and wait for that blood result. And so basically what occurs in these blood tests is that you take a simple blood draw and you are looking for what's called circulating tumor DNA or ctDNA. The companies that actually do this will be finding, be looking for these circulating tumor DNAs, and based upon that, be able to run studies on those cancerous cells that are found in the blood. Depending what those show, we can then consider getting a tissue test, okay? And so if we don't find a whole lot in the blood, we can then send a tissue test. The majority of us, though, go with what's called a complementary approach, which is that we send both a blood and tissue at the same time. So a patient comes to me, and I'm going to explain this in the next few slides, but patient comes to me, they have a diagnosis of advanced non-small cell lung cancer, and one of the first things that we will do is order the blood-based test and the tissue test at the same time. Interestingly enough, we get the blood-based test back quicker than we do the tissue. And we know that, the tumors themselves, if you take a biopsy of of a tumor, of a mass, depending where you biopsy that mass, let's say you picture like a circle, okay? And you pick here versus if you pick lower down, you actually may get different information, from that tissue. That is different than a blood test. A blood test will look for all the circulating tumor DNA and run tests on that. And so you may get different results. I mean, it's important to combine the results because there are times where we get an answer from one and not the other, and vice versa. And all it takes is one abnormality that can allow for us to utilize one of these targeted medications. A prime example is a patient of mine with non-small cell lung cancer who came to me with metastatic disease. We sent both tests. The blood test actually yielded that they had what's called an EGFR mutation. This is one of these actionable mutations or druggable mutations, meaning that the mutation that is within their cancer cells on a blood test, the circulating tumor DNA, allowed us to give a medication, and that medication has actually yielded unbelievable results. When we did the tissue test, which came back a couple of weeks later, we did not see that mutation in the tissue. But despite not seeing it in the tissue, the tumor is still responding. So it's very important to kind of go with this complementary approach. And generally that's done by your medical oncologist. This is just a summarization of some of the findings that we will have from our tumor tissue, as well as some of the blood tests, essentially allowing us to get informed diagnoses, allow for us to kind of give a prognosis to patients based on historical data with mutations, guide us to make the decisions for certain targetable mutations, as we discussed. There some of the immunotherapies, which I'm sure you've heard of or have seen on TV. We're utilizing that more and more, and certainly there are certain circumstances where we can omit chemotherapy. And these are based on biomarker studies, on tests that are done from the cancer itself, whether it's blood or tissue. So I just kind of want to go and kind of summarize how, as a medical oncologist, how we approach patients, and how we work them up. Okay. And this is just kind of understanding, early on versus later stages. So, generally for localized disease, right? So a tumor that's located in the lung and not spreading anywhere else. The test of choice is something called a bronchoscopy. This is an illustration of the type of procedure, going in through the oral route, down the trach into the lung area, and getting a sample, let's say from an abnormal left lung mass that's present there. Generally, it's accompanied by something called an endobronchial ultrasound. Basically, they go down and look at some of the lymph nodes. The reason why we do that is part of the staging, and they will take samples from lymph nodes as well as a lung mass to help stage the disease. The staging is for localized disease is based on the tumor itself that's in the lung, as well as the lymph nodes. For patients with what I call suspected metastatic disease, and the reason why I use the word suspected, is that you can never make a diagnosis of metastatic or stage 4 disease based on an imaging. Generally, it's an assumption, it's an understanding, but we like to get a sample of the suspected metastatic site. For example, if someone comes in with lung cancer, has something that's found in the liver or in the bone, sometimes in the brain, right? We think about doing a biopsy of that area to confirm stage 4 disease, and also allow us to be able to send tissue analysis or send studies to evaluate the tumor itself, again allowing more information. There are times where we do offer surgical resection for patients with metastatic disease. In other words, if someone presents with a large brain mass that is, causing symptoms, the neurosurgeons may operate on that. There's also times in certain circumstances where if a patient has, a single lung mass and a single lesion in the body that can be removed surgically, we will do that with the hopes of actually curing that patient, because there was no other sites of disease. That's a complex situation. It's kind of a unique situation because the majority of patients who have stage 4 disease will have more than one site of metastasis. This is in imaging, PET imaging that we offer our patients. So PET scans, I'm going to show you in the next slide, are a form of a CT scan. They're called PET CTs. And basically what they do is that they have this is the CT part, if you guys can see my mouse. This is a part of the PET, part of it. But basically what a PET scan does is it utilizes the CT component and also shows us the activity level of these areas of abnormalities. So for example, in this imaging, this is, three images here, but on the CT, you can see the abnormality and this is right, this is left. So on the right lower lung field, as well as an abnormality in an area just below the liver this is called the adrenal area above the kidneys. And so an abnormality there, that's confirmed on PET CT, both on this image and on this image. This is just two forms of a PET image, but you can see that, this person has an abnormality here. This is a situation where if the patient is felt to be resectable in the lung, and has a single lesion in the adrenal gland, that's a type of situation that can be considered for surgical removal if it was felt, to be operable from a surgical standpoint. I'm not a surgeon. I don't try to be a surgeon, but it's important, to involve our surgical team and have, very much a multidisciplinary approach. There are certain areas on a PET scan, just so you are aware, that they will always be positive. I don't need to go into all the details, but kidneys, because they're always flushing out, toxicity, toxins, I should say. The brain is always active because our brain is always working. The heart as well. This is, the heart's always pumping. You will see activity, and so certain times, I'm asked that question. What is that? My scan, and it says, no, that's normal. That's the normal activity of a beating heart. In addition to a PET scan, it's always recommended to do a brain MRI in all patients with a diagnosis of lung cancer. The reason being is that lung cancer can unfortunately spread to the brain. This is a MRI that shows, unfortunately, spread of cancer into the brain. These are a few of the abnormalities that are seen on a brain MRI. Sometimes patients are symptomatic, other times they are not. I generally, just so you're aware, and what I explain to patients, is that in lung cancer with brain metastases specifically, I generally tell them that they are kind of two separate entities, in the sense that the brain needs to be treated one way and the body needs to be treated another way. The reason being is that a lot of the general treatments we have for non-small cell lung cancer, and small cell lung cancer for that matter, but in terms of the purpose of this talk, the treatments we have that do well in the body don't usually work very well in the brain. Now, that's different with targeted medications. Okay, so some of the targeted or mutation positive lung cancers can actually respond well in the brain. Okay, so if we find a mutation, we have medications that work well in the brain. If we don't find a mutation, the general approach is chemotherapy, immunotherapy, and those don't work particularly well in the brain. And so the brain needs to be addressed separately, generally by way of surgical intervention, radiation therapy. We have things like what's called CyberKnife, which is a form of radiation therapy to kind of go in and zap these specific areas. And so it's always important. So in patients with stage 4 non-small cell lung cancer, and just to touch about it for 1 second, with small cell lung cancer, we really don't see actionable mutations. So it's actually not even recommended for small cell to check for biomarkers. Non-small cell, again, the 85 to 90% of lung cancers, it is recommended in all patients to have these mutational analyses done. Like I told you, blood-based test, tissue-based test. So if you have a patient with non-small cell lung cancer, stage 4, like I told you, the recommendation is that you do these molecular studies. In addition, they should have something called a PDL1 testing. So I'll talk about each one specifically. So the molecular analysis is done, and we see in roughly about a quarter of patients that they will have a mutation that allows us to give a targeted therapy, generally an oral medication. I actually just reviewed a report from a patient of mine that we just saw a couple of weeks ago, that we were waiting on the tissue-based test that was found to have one of these mutations called a RET mutation. It's actually 1 to 2% of all lung cancers, all non-small cell lung cancers, allows us to give a medication, and we're immediately switching his therapy. So it's very important to check for these things, because generally these oral medications are better tolerated than chemotherapy. They're more specific, for their cancers. The response rates are generally a bit higher. And so if we find these things, which they should be looked for, we have the option of giving them very effective treatments that are given oral route, well tolerated. So if we can find them, we need to find them. If they don't have a targetable mutation, right, which is the other kind of 75% of patients, this is 45 and 30, summarizing to 75, it's very important to do something called a PDL1 testing. So this is done specifically only on tissue. We actually run this test in-house, and so we can get that test back within a day or two. It's a very important test to run, because the percentage of that test, so the way that it is reported is either going to be less than 1%, which is considered negative, 1 to 49%, or more than 50%. Okay, so there's an approval for an immunotherapy to be given by itself without any chemotherapy in patients who have a PDL1 greater than or equal to 50%. So again, mutation is negative, run a PDL1. If it's more than 50%, they can get pembrolizumab. We see that in roughly about a third of patients. The other, percent that adds up, that summarizes to that 75%. So about, the other 2/3 of this group of patients will have a PDL1 that's less than 50%. And generally, of course, they have this negative mutation. Their PDL1 is less than 50%. The standard of care treatment is some sort of chemotherapy and immunotherapy. So obviously that also helps guide our treatment decisions, how we're going to approach these patients. And that's within the tissue-based studies. Now, like I told you, with the targeted mutations, you can find them in tissue, you can find in blood, you may find in one versus the other, or both. And so both, definitely need to be sent. This next slide is rather complex, so I'm not going to go through the details of what this is, but next generation sequencing is generally the tissue-based approach to biomarker studies. As you can tell, this is a very complex procedure. I will not even try to figure out how it's done, but I understand the results of the test, and really, be able to kind of summarize that to our patients. When you do the lung biopsy or a biopsy of a lesion in the body, and send it out for analysis, you're always going to find, just so you're aware, mutations present. Okay. But what we're really looking for is targetable mutations. So yes, there are mutations that are harbored within cancers, but they don't have a medication. Perhaps they don't have it now. As we've gone along, we've added more and more medications. We found more and more what are called driver mutations. I didn't use that word before, but driver mutation is a mutation that is essentially promoting the growth of this cancer. And those that have a target, we want to find it. So unfortunately, there are times where we send out these tests, we find that there are mutations, but we don't yet have a drug for it. There are ongoing clinical trials with some of these mutations. And so when we start to run out of treatment options, or someone's not tolerating some of the medications we have them on, we can offer them clinical trials. We ourselves have clinical trials based on some of these tissue studies that are done, these next generation sequencings that are done. There are other sites across the country that also offer clinical trials based upon some of these tissue analyses. These are just some of the methods that we use. As you can tell, there's multiple methods of studies that are done. You don't need to know the details of these as well, but just know that as time has gone on, we've found more and more alterations. We've studied more and more medications to allow us to treat all of these. This is just a pie graph of the percentage of mutations that we're finding. So as I kind of told you before, um, about 40% of the time you will not find any sort of mutation. The other, 60 something percent, you will find a mutation, but again, not all these mutations are actionable. And so, the actionable mutations, at least, as it stands, end of November 2023, the actionable, mutations still remain to be about a third of patients, a little less than a third of patients, as I showed you in the prior slide. But these are some of the mutations. These are some of the higher percentage. We have these KRAS mutations. We recently had approval for a type of KRAS mutation. Again, KRAS is seen in about a quarter of non-small cell lung cancers, but only a small percentage of those KRAS mutations will actually be actionable. We have, of course, EGFR, ALK, and then we have some rarer mutations, that again have targets that we can use. PD-L1, as I discussed in the prior slide, this has, I didn't really explain so much in detail, but PD-L1, I told you about the percentage, the more than 50, 1 to 49, less than 1%. But PD-L1, as it's related, it has to do with the immune system. Okay, so the higher the percentage, the higher the chances that the immune system can be activated to treat. Okay, and so immunotherapy, which is the type of treatments that we offer patients as standard of care treatment for patients who have non-mutational non-small cell lung cancer, what the way that the medication works is it actually spikes up the immune system to fight off cancer cells. And so as that percentage goes up, the chance that the response rate to these drugs also goes up. This is a depiction of, again, as I told you, there's a lot of heterogeneity. What that means is that if you take a sample from here versus here, so top versus lower, you may actually get different results. Okay, and so interestingly enough, when they took a sample from this part of the tissue, or when they looked under the microscope from this part, they found that this patient was PD-L1 negative. When they checked down here, they actually found positive results of PD-L1, perhaps allowing us to use some of these immunotherapies. So it really can vary. Unfortunately, this is very complex, and I think there's a lot of room for research and ongoing research, how we best curtail our medications. Like in this picture, you could offer it, and so that remains a challenge. It remains an area that we're really trying to improve, and hopefully we'll have better understanding as time goes on. Again, this has to do with different types of areas in the body. So this is a patient with lung cancer, depending where they biopsy, including the lung, lymph node, liver, adrenal, brain. This is multiple patients, but what they found is that the PD-L1 percentage, right, from 0 to 100, can certainly vary depending where you biopsy. Okay, and so these are kind of some of the midpoints, of median of the percentage, and depending where you biopsy from, you may get slightly different results. So obviously that may change, the approach depending where it's biopsied from. This was just a study, a summarization of why we do things the way we do it. So these are in patients with PD-L1 positive more than 50%, who are randomized to treatment with either immunotherapy by itself versus chemotherapy, which was standard of care. And it did allow for crossover. So patients who got this and progressed could go to immunotherapy. And these are a summarization. This has to do with the overall survival over time. And we can see a drastic difference between those that got immunotherapy, versus chemotherapy. And it really led to, the FDA approval and the change in treatment paradigm for patients who have PD-L1 more than 50%. So like I told you before, needs to be checked, especially when you find that negative mutation. We certainly know that, as the population ages and the life expectancy is higher, we certainly know that, and I should say, in addition, we also know that cancer increases as patients age. We deal with a lot of patients who come to us, who are elderly, who are above 75, above 80. We've seen patients into their 90s that come to us with metastatic non-small cell lung cancer. And it's very important to check, for these things, because we know that, side effects of chemotherapy are dramatically higher in, patients who are over the age of 70, 75. And if we're able to omit or avoid the use of chemotherapy because they have a high PD-L1, we certainly try to offer that to our patients, primarily to prevent significant side effects, because all these medicines have their potential for risk of side effects, and certainly, the last thing we want to do is to treat someone and cause more harm than good. And so, I have patients with advanced and metastatic non-small cell lung cancer, amongst other cancers, into their late 80s, 90s, that we have them on immunotherapy. They're doing great. It's a well-tolerated medicine. It doesn't have the side effect profile that we see with chemotherapy, including risk of severe infections and things like that. Immunotherapy is not the purpose of this talk. I think I talked previously to Gildan's Club about immunotherapy. Has its own side effect profile, including immune-related side effects. I'm not going to get into all these details, but know that it's generally well tolerated, and certainly if we're able to give it by itself and avoid chemotherapy, we want to do that. Another test that we do based on tissue is something called tumor mutation burden. We shorten it to TMB. Certain cancers will have higher mutation burden. And you can see here, lung adenocarcinoma, lung squamous cell carcinoma is on the high end of mutated proteins, versus things like thyroid, acute myeloid leukemia, type of kidney cancer has less mutation. Generally, the higher the mutation burden, the higher the chance of immunotherapy working. And so, interestingly enough, the approval of immunotherapy was first done in melanoma. There's a lot of studies in lung cancer. They work well. For some reason, they don't work very well in pancreas. They do work well in bladder. We use it in cervical. We use it in head and neck. We use it in stomach. We use it in endometrial. We use it in colon. So, we use in kidney cancer. So generally, this kind of correlates. The only one that, and we're not going to talk in detail, but the only one that, for whatever reason, is pancreas, just doesn't seem to work very well with immunotherapy. But certainly, the higher the mutation burden, higher the chance of responding to immunotherapy. It's one of the tests that is ordered with the tissue analysis, and is reported. And so certainly we want to know that information before we make a decision. In addition to understanding the kind of biology of the disease, we also know that those that have a high TMB in lung cancer, as well as other cancers, generally respond well to PD-L1 inhibitors or immunotherapy drugs. And so this is a evaluation of and treatment of patients with non-small cell lung cancer utilizing TMB. And it actually led to the approval of pembrolizumab for patients who have this high TMB. The cutoff is a number 10. You don't need to know all these details, but just understand that there's high, there's intermediate, and there's low. For the ones that have high, they can get pembrolizumab, which is a type of immunotherapy, as we discussed previously. Remember, PD-L1 more than 50%. Another indication is high TMB. These are tests that are done. Another example of a biomarker, that is done in patients with non-small cell lung cancer, as well as other cancers. So liquid biopsies, this is just a cartoon of how we go about doing liquid biopsies. And so kind of like the term liquid biopsy because it just sounds kind of cool. But essentially what we're doing is taking a blood sample. I just had a patient today, not a lung cancer patient, but another type of cancer patient, unfortunately newly diagnosed stage 4 disease. And so I, as I told you, as we do with everyone, get the tissue sent out and do a blood test. And so the blood test is done, it's sent to a lab. Actually, some of these blood tests can be done at the confines of the patient's own house. And so they will send phlebotomists to their house and do the test if they can't come into the clinic, or if it's more convenient to them. And so, all this is in place. And, again, they're looking for those abnormal cells and then, run the molecular testing to allow for us to, again, make those treatment decisions. So what is the utility of liquid biopsies in clinical practice? So, certainly it should be done in collaboration, or, excuse me, collectively with tissue biopsies, number one. Number two, all patients with non-small cell lung cancer should have a liquid biopsy or tissue biopsy or both prior to starting frontline treatment. I'm not going to go into all the details of why that is, but just understand that generally we don't try to start patients on chemo and immunotherapy if we don't know their mutational analysis. A lot of that has to do with the fact that the patients may not respond as well if they get immunotherapy and then need to be switched to an oral medication. They can also have increased risk of side effects if you start immunotherapy and then switch over. So generally, we like to get that information before we give them any sort of medication. We can assess for tumor resistance, so we can oftentimes repeat some of these studies if patients fail their frontline treatment options, or second or third or fourth, where we can assess to see if there's any new mutations that may have formed that can occur. We can also utilize these biopsies. This is more kind of in clinical clinical trials. We're not really doing this quite yet, but we're kind of getting there. And that is that we're trying to assess the response to treatment. Generally, the way that we assess response is by way of imaging tests. So, we talked about those imaging tests before you start treatment. Generally, repeat those imaging tests to assess the response. But we're now, maybe able to use some of these blood tests to see how the cancer is responding in the blood. We also can utilize them after surgery. So if you're looking to see if there's any circulating tumor DNA after surgery, where your MRD is minimal residual disease. And so you're trying to make sure that if there was disease present prior to surgery, you do the surgery, you drop off. And I'll show that in the next slide as well. And then also, something, to look forward to in the future is that we may be able to utilize these biopsies to actually diagnose lung cancer. So that is not in place as of yet. It's being studied. There's a lot of, it's definitely a hot topic in our world to look at blood tests to help with screening and diagnosis. It's not there yet, but perhaps we'll get there in the coming years. So this is some of the, the reason, or some of the indications and how we do things, as we talked about, for early detection of cancer. Again, not happening yet, but perhaps we'll get there. Following, this is levels of circulating tumor DNA in the blood. Following the levels, if we give preoperative treatment called neoadjuvant treatment, then do the surgery, watching to see if it drops off and we get into this MRD state, this minimal residual disease. We then follow them over time, and you can look and see if there's any evidence of recurrence. It's another way that we could hopefully utilize liquid biopsies. Again, not approved, but being studied. If you start a patient, who has metastatic disease on treatment, you could watch to see what the response is like. If you see that the response, that the ctDNA is going up, you can then send more, analysis, see if there's any resistance to these medications, essentially trying to aid you in your decision making. And so it's become, very, very helpful to us as medical oncologists. Kind of just to summarize, some of the things we discussed today. Non-small cell lung cancer is not one disease, but many. Obviously, we have different types of non-small cell lung cancers we discussed, including the most common of which is adenocarcinoma. The second most common is called squamous carcinoma, which obviously we talked about squamous versus non-squamous. And then within, all the non-small cell lung cancers, we have the various types of mutations that are present, the importance of some of those things like the PD-L1 testing. All of that is very important for us as clinicians. And most importantly, it's for the patients, because as this next slide shows, as time has gone on, this is just over not even 20 years. I guess we're almost at 20 years at this point. Some of the development of these medications leading to the approval in metastatic non-small cell as well as resectable or surgical operable non-small cell lung cancer. As you can tell, there's been a lot of medications, a lot of advancement in the field of non-small cell lung cancer, allowing us many different options, allowing us to curtail our treatments. And ultimately, as probably one of the most important things to show is this, and that is that we have significantly decreased the annual rate of cancer deaths in specifically in non-small cell lung cancer. A lot of that has to do with finding it early, as we talked earlier, stopping, population or reducing the population from smoking, and certainly this curtailed treatment approach with tissue analysis, blood analysis, to allow for us to offer all the potential options for our patients.